turning now to the Big Apple, where new multi-million-dollar fraud schemes are coming to light. Just this week, two scammers pleading guilty to a $68 million fraud scheme tied to the state's Medicaid home care program. The crooks billed for millions in services that they never provided. And unfortunately, it's not the only million-dollar scam recently exposed. News Nation's Leah Lando live in Manhattan tonight with the very latest. Leah, what are we learning on this?
Yes, Natasha, we've been looking into this just this past week, as you mentioned, two big cases in court involving millions of dollars in kickbacks and fraudulent billing to Medicaid. And we're talking about another notable case tonight that involves a program called CDPAP. Now, if you're not familiar with that, it is for people who need to be cared for, but they don't want to go to a nursing home. So through Medicaid, they can hire their own caretaker. They get to choose if it's a friend or a relative as long as they go through the process. And while it sounds good, it is also a big target for scammers. This past week, two New Yorkers pled guilty to a $68 million fraud scheme tied to CDPAP, billing Medicaid for services at Brooklyn-based adult daycares that never actually happened. These fraudsters were, quote, large-scale recruiters who bribed patients with laundered cash and billed Medicaid over $68 million for services that were not provided.
It started at 4:41 a.m. That was the first moment the first black SUV rolled beneath the glowing emergency entrance sign of the hospital network's flagship Manhattan campus. The city was still half asleep. Rain from earlier in the night clung to the asphalt in reflective streaks. Steam rose from a street vent near the ambulance bay, twisting through the cold blue light of the pre-dawn hour. A sanitation truck groaned somewhere down the avenue. A lone cab drifted past the main entrance without slowing. Nothing about the street suggested that, inside one of the most respected medical systems in New York, federal agents were seconds away from detonating one of the biggest healthcare fraud scandals in the country. Then the rest of the convoy arrived. Two more SUVs slid into the loading lane. A white federal evidence truck stopped near the side administration entrance. Another team moved around the back toward the surgical records wing and physician executive offices. By 4:45 a.m., the outer points were sealed. By 4:47 a.m., agents had taken positions at the main lobby, the billing office corridor, the surgical archives department, and the private elevators leading to the executive floor. No sirens, no press, no warning. Only low radio traffic, wet footsteps on concrete, and the hard metallic sound of breaching tools being set in place beneath hospital walls that had long projected prestige, healing, and trust. At 4:49 a.m., the signal came. At 4:50 a.m., the administrative entrance was breached. At 4:52 a.m., agents flooded the executive wing. Inside, the building still looked exactly like what the public believed it to be. Polished stone floors, donor plaques, quiet hallways, framed photos of smiling surgeons beside grateful patients, mission statements about excellence, compassion, innovation. To the families who passed through those corridors every day, it was a place of hope. But before dawn, investigators believed it was something else too, a machine. By 4:56 a.m., agents had entered the surgical scheduling department. By 5:01 a.m., they seized operating room allocation logs, physician block schedules, and internal emails linking procedure volumes to performance targets. At 5:07 a.m., another team forced open a locked records room and found sealed chart review binders marked by department, surgeon, and something far more disturbing. Conversion rates. Not outcomes, not recovery. Conversion rates. That was the first moment the entire case darkened. At 5:12 a.m., agents in the compliance office recovered internal audits showing repeated warnings about questionable surgical necessity. At 5:18 a.m., digital forensics teams inside the command truck began comparing those files against insurer billing data already under investigation. And at 5:24 a.m., the phrase that changed everything was spoken aloud inside the mobile command unit parked beneath the ambulance ramp. Procedure farming, not aggressive medicine. Not isolated overbilling, procedure farming. By 5:31 a.m., agents at two affiliated campuses in Brooklyn and Queens were reporting the same thing. Identical scheduling pressure, suspicious diagnostic patterns, and surgeons whose case volumes looked less like medicine and more like factory output. At 5:38 a.m., the first indictment number was confirmed. 19 surgeons, 19. That was how many surgeons federal prosecutors believed were tied directly to the network's fraudulent billing, false necessity certifications, insurance manipulation, and medically unjustified operations. By 5:46 a.m., the financial investigators in the command van spoke the second number, the one that would define the scandal nationally. $1.2 billion. That was how much investigators believed had been extracted through insurance fraud, surgical upcoding, phantom complexity charges, false diagnoses, bundled post-op billing, medically unnecessary procedures, and corporate pressure systems built around maximizing reimbursements. $1.2 billion. And according to investigators, a horrifying part of that money came from surgeries that should never have happened at all. By 5:53 a.m., secondary warrants were being served at surgeons' private offices, 2 physician-owned consulting firms, the network's central billing contractor, and a luxury townhouse linked to the chairman of surgery. By 6:02 a.m., agents were wheeling out boxes of patient charts, peer review files, or utilization reports, and executive compensation records. According to the working theory, the network scheme operated on multiple levels at once. At the first level, insurers were billed for procedures classified as more complex, more urgent, or more medically necessary than the evidence supported. Diagnoses were escalated. Conservative treatment failures were overstated. Risks were framed in alarmist ways. Patients who might have safely continued monitoring medication, therapy, or watchful waiting were allegedly pushed towards surgery because surgery paid more. At the second level, once patients entered the surgical pipeline, the revenue grew. Pre-op testing, surgical fees, anesthesia, assistant billing, hospital stays, pathology, imaging, post-op follow-ups, device charges, complication billing, revision procedures. Every unnecessary operation created a halo of additional billable events around it. At the third level came the institutional pressure. Internal dashboards, block time incentives, or utilization benchmarks, referral targets, compensation structures that rewarded volume. Not openly, perhaps. Not in the crude language of a cartel, but in the polished managerial language of modern healthcare finance. Efficiency, growth, capture, service line optimization, conversion, productivity. And buried under all of it, according to investigators, was the ugliest truth of the case. Some patients were healthy enough or stable enough not to need the knife at all. That was what made the title so explosive. Unnecessary surgeries on healthy patients. Not just overbilled surgeries, not just marginal surgeries. Surgeries that, in the case theory, had no defensible medical urgency and sometimes no true necessity whatsoever. The first warning signs reportedly emerged from insurance review analysts who noticed abnormal surgical density in certain departments across the network. Some specialties were converting consultations into operations at rates far above national norms. Certain diagnosis to surgery timelines were unnaturally short. Complication patterns suggested operations were being performed on cases that should have had more conservative workups first. At first, those anomalies could be explained away. Maybe the network drew harder cases. Maybe it specialized in high-acuity referrals. But then the charts began to tell a different story. Imaging that did not support what had been told to the patient. Symptoms documented as severe, despite earlier notes suggesting mild or inconsistent complaints. Second opinion requests discouraged. Template language repeated across unrelated cases. Diagnostic phrases copied from one chart to another, and peer review concerns quietly buried instead of escalated. That was when the case stopped looking like aggressive billing. It started looking like an assembly line. The breakthrough reportedly came from a surgical nurse coordinator who had spent years in one of the network's busiest OR divisions. She described pressure that seemed to flow downward from leadership. Certain surgeons were protected no matter how many complications followed. Block time was treated like territory. Cases that might have been delayed for additional testing were advanced because surgeons didn't want to lose slots. Patients were said to fall off if they had too much time to think. Families asking for second opinions were subtly made to feel reckless. Staff who raised questions about necessity were labeled difficult or not team-oriented. In other words, the operating room had stopped being purely a place of medicine. It had become a place of extraction. One internal document investigators believed was especially devastating. It tracked consultation to surgery conversion percentages by physician, location, and specialty line. It did not center patient recovery. It did not center avoided harm. It centered how many consultations became procedures and how much revenue those procedures generated across downstream billing categories. That kind of document destroys every benign explanation at once, because medicine does not talk that way unless business has already taken control. The surgeons at the center of the case were not the only ones who allegedly benefited. The hospital system itself was structured to feed on volume. Executive bonuses rose with service line profitability. Operating room efficiency metrics were celebrated. Certain specialties were promoted aggressively in marketing. Physician-owned side entities, consulting arrangements, imaging centers, device relationships, and post-operative management companies all helped widen the financial capture around each patient pushed toward surgery. That is how a fraud network grows from greed into empire. Not by one doctor making bad choices, by a system aligning incentives so that the knife becomes the fastest road to money. And the patients, according to investigators, often had no realistic way to defend themselves. They were scared. That is one of the cruelest parts of hospital fraud involving surgery. A frightened patient is easy to move. Tell a person there might be a hidden cancer risk, a silent rupture risk, a neurological danger, a cardiac complication, a narrowing that could become catastrophic, and many will sign what they are told to sign, especially inside a hospital carrying a trusted name, especially when the man advising them wears a surgical coat and speaks with certainty. That is not informed consent, not if the necessity itself is corrupted. That is manipulation dressed up as care. By midday, the fallout had spread across New York. Scheduled surgeries were being postponed. Patients were calling in panic. Families were demanding records. Insurance companies were freezing payments. Rival hospitals were quietly reviewing referred cases that suddenly looked suspicious in hindsight. Reporters had begun hearing whispers of healthy patients receiving procedures they never truly needed. Legal departments inside the network were already drowning. Still, investigators believed the financial fraud, terrible as it was, told only part of the story. Because once unnecessary surgery enters the picture, the harm is not abstract. It is carved into bodies. A person who did not need surgery but received it anyway may carry scars, chronic pain, permanent complications, anesthesia risk, infection exposure, lost wages, emotional trauma, and years of mistrust. Some may face revision procedures. Some may lose organs, mobility, reproductive capacity, or function that can never be restored. The bill can be repaid in theory. The body cannot. That is what made the $1.2 billion figure both enormous and almost secondary. The real damage lived in the patients. One person pushed into a surgery they did not need is a scandal. Hundreds or more, investigators feared, becomes a medical catastrophe. The hospital network's leadership allegedly helped sustain it by keeping the machine polished. Marketing talked about excellence. Internal compliance softened language. Peer review stalled. Certain bad outcome patterns were treated as noise instead of warning. Revenue success made it easier to ignore what the charts were beginning to say. Money has a way of making institutions hear only what protects the structure. And structures like this do not collapse easily. People inside sense that something is wrong long before federal agents arrive. Nurses notice the speed. Coders notice the repetition. Junior doctors notice the same diagnoses surfacing over and over. Schedulers notice how aggressively certain physicians fight for operating room time. But sensing is not enough. In a famous hospital system, rank protects itself. Reputation becomes armor. People convince themselves the prestigious surgeon must know more. The chairman must have reasons. The metrics must reflect excellence, not corruption. That is why raids like this matter. They force the door open when status has become a shield. By afternoon, more internal records were surfacing. Emails about surgical capture, compensation discussions linked to volume. Concerns raised by internal reviewers and quietly buried. Patterns showing patients who sought outside opinions often did not end up needing procedures after all. That kind of evidence made the case harder and harder to spin as aggressive but lawful medicine. No honest hospital tracks surgery this way if patient necessity is truly the priority. No ethical surgeon needs conversion targets to guide judgment. And no medical network should ever make more money by convincing healthy or stable people that their bodies need cutting open. As evening fell, evidence teams were still cataloging charts, drives, billing files, compensation records, and peer review documents. Prosecutors were refining the indictment structure for the 19 surgeons. Insurers were preparing for waves of litigation. Patients were beginning to realize that operations they had been told were urgent may have been profitable instead. The network's towers still stood above the city, still gleaming, still branded with the language of care. But by then, the illusion was dead. Because before sunrise, federal agents had revealed what investigators believed was hidden behind the hospital's polished reputation all along. Not just fraud, but a surgical business model built on fear, manipulation, and the monetization of trust. At 4:41 a.m., it was still just another famous New York hospital before dawn. By 5:24 a.m., agents were openly calling it procedure farming. By 5:38 a.m., 19 surgeons stood at the center of the case. By 5:46 a.m., the financial exposure had reached $1.2 billion, and by the end of the day, the image of elite medicine had collapsed into something far darker. A hospital network accused of turning healthy bodies into operating room inventory, turning surgeons into revenue engines, and turning insurance into a vault opened one unnecessary surgery at a time. The offices were breached, the charts were seized, the surgeons were named. But one question remained after the raid was over. How many people walked into that hospital trusting the diagnosis and woke up altered forever by an operation they